what we had done with what we called SANE, or Stanford Accelerated Intelligent Neuromodulation Therapy, is that we came up with a way of reorganizing conventional TMS, which had been around for some time, reorganizing it in time and in space, right? And so with conventional rTMS, it had developed in the mid-'80s, first used as a therapeutic within clinical trials by my mentor, Mark George, when he was at NIH in the mid-'90s, approved by the FDA in the kind of mid to late 2000s. It utilized, kind of average skull positions to find an average spot to stimulate, which, at the time, given the technology that was available, that was the right call, right?
Can I pause for 1 second just to give some additional context?
Yeah.
What does TMS stand for?
Transcranial magnetic stimulation.
And it was originally developed for what?
As a motor probe by Tony Barker in the UK. And the idea is this idea of Faraday's law. So Faraday's law is this idea that if you pulse a magnet, you can generate current in electrically conducting substances. So if I take an electromagnet, if I take a TMS machine to the beach and I try to pulse the sand, nothing's going to happen because sand is not, as you know, electrically conducting at all. It's an insulator. And so if you put a TMS coil or any electromagnet next to a wire, a copper wire, or speaker wire, or whatever, you can generate current in that wire. If you put the coil on the head, it will bypass the skin, scalp, skull, and induce current in the electrically conducting substance in the brain, the kind of brain tissue, right? And so you're able to selectively turn on cortical neurons without really interacting with much of the rest of the head. People do feel something because of the nerves in the scalp, but your brain can't feel anything. So that's like scalp nerves. And so as they did in the 80s, just kind of send a single pulse. It doesn't really change the brain, but you can probe the brain, right? So I could take that coil from the mid 80s and I could put it over my hand representation to make my thumb move. I can put it over my wrist representation of my brain. I can make my wrist move. And it's organized in this stereotyped way such that essentially the head face area is like closer to the ear, and you can march up to the midline of the skull such that when you get to the midline, you're able to actually move the foot and the leg. If you have a certain kind of coil, you can do that. And so you can actually probe the entire motor system and make all of it move without having any volition to it.
Question, what is the value of this probe?
So the value of a probe itself is just,
figuring out the mapping.
Yeah, it's a mapping exercise initially, right? Like, where is everything? Is it the same in everybody? Is it consistent? And they wanted to kind of have a way of doing that non-invasively. Penrose and others had been doing this invasively as neurosurgeons for 100 years, I guess 50 years at that point. And so they wanted to be able to emulate what the surgeons could do in epilepsy patients when they're doing epilepsy surgery non-invasively. And then what folks realized over the next 10 years is we can send a signal into the brain that's like Morse code and basically send this signal to change the excitability of the brain. And we can measure it, if we do it in motor cortex, by how much the thumb moves with a set amplitude out of the machine. So if I get X movement, I can make, from stimulating here, I can make the thumb move X amount. And then I send this Morse code signal into the brain to tell it to tone down or to kind of be less excitable. And then I send that same intensity back in, the thumb will move half as much. And so you've toned down cortical excitability. If instead I get this measurement of X, and then instead of putting in what we call inhibitory or depotentiating stimulation, we put in excitatory potentiating stimulation into the brain. And we do that, and then we measure again, it'll be 2X. So we knew by the mid-'90s that we could actually move around how excitable the brain was in these normal, healthy, control volunteer motor cortices. And so the aha moment for Mark and his team was this idea that, depression at that time on PET scans, on SPECT scans, was this kind of hypoactivity, hypometabolism.
Meaning lower.
Lower, yeah. Lower activity, lower metabolism of the prefrontal cortex, right? Where the prefrontal cortex just isn't as active, isn't as robust as it is in normal healthy controls. And so he had this idea, well, could we use this excitatory stimulation to drive up activity. And so that was the aha moment in the kind of first version of this. But they were, super careful. There'd been, some seizures in the early days from trying to figure out how all of this works. And so they wanted to do a stimulation approach that wasn't going to have much in the way of risk. And so they had this, once a day, very extended protocol. And because of the mid-90s, it was very hard to get cheap brain scans on patients. And so this idea that they were going to have to use kind of average coordinates to target it. And so they get average skull measurements, and then they would do kind of a low dose sort of approach once a day and do that out for weeks, and then it extended out to months. And so the original TMS trials and the original approval was this less efficient version that basically utilized kind of a low efficiency signal into the brain and used kind of average coordinates to place the coil.
So average coordinates meaning, just by clumsy analogy, like we can't take an x-ray of you, but we do have 100 other x-rays that seem to indicate roughly this is where you have your fracture. So we're going to aim at those coordinates.
That's right. Yeah, that's right.
And the once a day protocol, I've heard the number 36 from somewhere, but is it somewhere in generally like the 30 to 40 session range?
Yeah, that's exactly right.
So we're looking at, let's just call it for a placeholder, 30 to 40 sessions, one per day, to perhaps not necessarily conjure an image, but remove an image from the minds of some listeners. They may be thinking, this is a beautiful mind. This is somebody chomping down on a wallet or a piece of wood, getting electroconvulsive therapy.
Yep.
These are not the same thing.
It's actually the opposite. The goal of electroconvulsive therapy, or ECT, which has been around for 100 years, is to produce a therapeutic seizure. And some people with autobiographical memory troubles, it's pretty underutilized as a treatment in psychiatry because of these issues, because of particularly One Flew Over the Cuckoo's Nest and that story. And that movie culturally has actually had an impact on ECT. And it's one of these things that's kind of, for a lot of patients, a last-ditch resort because of the concerns around this, the side effects. TMS is different, right? You're not trying to induce a seizure. In fact, you're not trying to, have any sort of change in cognition. I always tell patients it's really boring. We have like Netflix running in the background, and people have their Netflix movie that they keep watching every day. It's basically just, once folks get used to it, it's just part of a routine where they're sitting there and watching their show or whatever it is, and the stimulator is turning the brain on. And unlike ECT, there's no anesthesia. There's really no need for anything. You can do this in an outpatient setting. But the old forms of TMS are extremely slow. You can't use that in a psychiatric emergency. And so this is something that happens over a couple of months. And it's tricky for some people. Like if you're a working person and you have to do TMS during, conventional TMS during kind of business hours, you basically have to tell your boss or sneak out of the office or whatever it is and go do an hour and a half during the middle of the day, during like standard kind of banker's hours, to be able to do this. And it's hard to do that over a couple of months. And it doesn't address these kind of high acuity emergencies. And so we got very interested in this idea of, can we, like I said earlier, reorganize the stimulation in time and space? Space being, can we personalize it to each person's brain? I can talk about that in greater detail. And then can we compress these 6-week courses, in this case, into a single day? So that's why Deirdre was able to get well in a day, is because we gave her a whole 6-week course in a day.
You gave her how many sessions?
So that's 10 triple dose sessions. And so it's like 30 total equivalent sessions in a day. And so the FDA cleared 600 pulses of ITBS once a day, 5 days a week for 6 weeks in 2018.
And that was for major depressive disorder?
That was major depressive disorder. And so we give a triple dose every session, so 1,800 pulses. And so after 10 sessions, you've got the equivalent of 30 sessions worth in that first day. And you do that for 5 days. And so people are getting the dose equivalent of 7.5 months worth of TMS in 5 days. Surprising to us that it was this linear, is that, you just pick up remitters as you progress through the days.
What do you mean by remitters?
People who completely lose all of their depressive symptoms to a level that is within the normal range. So they're rating at the same level as somebody who's not depressed. We can get people there on an average of 2.6 days, and we're able to do that by, personalizing the target and then being able to deliver treatment into that target, a lot of treatment over a short period of time. And so what's useful about that is somebody can be in a really pretty bad state on Monday morning. They can take a week off of vacation, or they may end up being on the inpatient unit or whatever it is, but they can, go out, get this done, and get back to work in a time frame that's actually reasonable. And that was really our goal. How do we get people acutely out of these high acuity settings and into a state of wellness quick enough that it doesn't make a major impact on their lives?
May I add one thing to that?
Yeah.
Which is, I've had a number of friends, and I've certainly heard of many cases where people with certain professions, airline pilots, firefighters, police officers, there are many more, will not report any type of mental health issue because they will be suspended in a lot of cases, or relieved of duty, right? They'll be forced to take time off. And in a case like this, where you have a compressed protocol, there's the possibility of taking PTO or taking a week off and doing this treatment. Whereas, like you said, doing it during banker's hours over months is going to be highly visible, right?
Yes.
And until the entire system changes, which is going to take time, if it happens at all, this would be an incredibly attractive alternable protocol if it were to work. So please continue.
That's the way that we thought about it, right? Is can we, take folks who need to get well quickly. I mean, we had people in conventional TMS courses where they're in really bad shape. They lose their job halfway through. Maybe they get better at the end of it, but it took so long. And so it's one of these things, if we can compress that up and get them well in a short period of time and get them out of it, it gets people back to their lives and it has a low impact.